Okay, imagine for a second that you're a medical detective. You're faced with a highly vulnerable pediatric patient, a young child, and you need to look deep inside their urinary system to find a hidden, potentially dangerous anatomical defect. But, well, there's a catch. The traditional tools you'd normally use, they expose these tiny developing bodies to incredibly high and, frankly, concerning amounts of radiation. So how do you solve this case safely?
What if I told you there's a diagnostic method that slashes that radiation exposure down to less than 1/20th of the conventional gold standard? It's a completely staggering reduction, and it absolutely changes the risk profile for these young patients.
Welcome to this explainer. I'm literally so thrilled to have you here today because we're taking a deep dive into a real game changer of a medical procedure. It's called radionuclide cystography. We're going to explore exactly how this incredible tool has become the absolute gold standard for diagnosing and monitoring a tricky condition known as vesicoureteral reflux, or VUR, in children.
All right, here's our roadmap for today. First, introducing radionuclide cystography. Second, why choose this method. Third, direct versus indirect modalities. Fourth, reading the scans. And fifth, strengths and limitations. Let's dive in.
Section 1. Introducing radionuclide cystography.
So, think of the human urinary tract kind of like a highly efficient plumbing system, right? Normally, fluid is supposed to flow in one direction only, down and out. But vesicoureteral reflux, or VUR, is an anatomical defect where urine actually flows backward from the bladder, up into the ureters, and all the way back up into the kidneys. It's essentially a broken biological one-way valve. And as you can probably guess, this backward flow can cause some severe, recurring infections and even long-term kidney damage.
To really put this broken valve scenario into perspective, when kids present with recurrent urinary tract infections, an astonishing 30 to 50% of them actually have underlying VUR. That's huge. That is exactly why radionuclide cystography is absolutely crucial as a primary assessment tool. But it doesn't just stop there. It's also used to objectively assess if a surgery actually worked, for proactive genetic screening of siblings who might have hereditary risks, and for routine monitoring to track the disease's progression.
Section 2. Why choose this method?
Just look at this stark comparison. That massive red circle, that represents the 300 millirads of radiation delivered to a patient's ovary during a conventional VCUG. Now look at that tiny little green dot. That's the radionuclide cystogram, coming in at a mere 5 millirads. RC delivers excellent diagnostic sensitivity while exposing the child to less than 1/20th the radiation of conventional methods. When you're dealing with pediatric patients who might literally need multiple scans over their childhood, that tiny green dot is everything.
Section 3. Direct versus indirect modalities.
Okay, it's super important to draw a hard line between these two different approaches. The direct method requires a Foley catheter to instill the radiotracer, which is typically technetium-99m sulfur colloid or TCO4, directly into the bladder. Now, its major advantage is that it actively detects VUR during the filling phase, though of course the catheterization is invasive. On the flip side, the indirect method requires no catheter at all. The tracer, usually technetium-99m DTPA or MAG3, is injected intravenously. This gives highly valuable info on baseline kidney function, but the big limitation here is that it requires a cooperative patient who already has good baseline renal function.
So, how in the world do we choose? Well, it's all about matching the protocol to the specific patient profile. The direct profile targets non-toilet trained children under 3 years old or older girls presenting with recurrent UTIs who maybe previously had a normal indirect scan. Conversely, the indirect profile is strictly for children who are successfully toilet trained and can actually follow instructions. This allows doctors to assess how well their dilated upper tracts drain when the bladder is full versus when it's empty.
Let's look at how the direct acquisition is actually set up in the clinic. The patient lies supine, flat on their back, with the gamma camera positioned below the examination table to capture the whole entire field of view, so both the bladder and the kidneys. The clinical team calculates the required bladder capacity using a very specific formula. It's the child's age in years, plus 1 multiplied by 30 cc. They then fill the bladder until they hit strict endpoints, like if the flow reverses, if the drip slows down significantly, or if the patient just begins voiding around the catheter.
And the imaging itself, it happens in 3 highly controlled continuous phases. Phase 1 is continuous filling for 60 seconds. Phase 2 requires high temporal resolution for 120 seconds of active voiding. And finally, Phase 3 captures 30 seconds of post-void recovery. Throughout this whole process, the clinical team has to rigorously document the exact volume instilled, the volume voided, and the pre- and post-void count rates.
Now contrast that highly controlled direct filling with the indirect clinical workflow. Here, we start with an initial baseline dynamic renal scan. Then the patient actually leaves the room. Yep, they go hang out in a waiting room for a hydration phase, actively drinking to fill their bladder naturally. Finally, they come back from micturition in front of a vertically positioned gamma camera. The absolutely critical parameter to remember here is that this exam is only considered finished when both the kidneys and the bladder are completely empty.
But wait, what happens if they aren't empty? If radiotracer activity sticks around in the system after that first void, clinicians have a handy troubleshooting protocol. Pathway A addresses standard retention by simply sending the child back out to the waiting room for more hydration and scanning them again when they naturally need to pee. But Pathway B is for when activity persists specifically in a dilated collecting system. In this case, clinicians administer oral furosemide, wait exactly 15 minutes, and then perform another scan to definitively rule out any structural obstruction.
Section 4. Reading the scans.
Now, what's really interesting here is that first we have to establish a healthy baseline. Take a look at this beautiful flipbook sequence of a normal scan. During the filling phase on the left, the bright radiotracer remains perfectly, cleanly isolated right there within the expanding boundary of the bladder. During the middle voiding phase, we see smooth contraction and rapid, complete evacuation. And in the post-void state on the right, the whole system is completely empty with absolutely no aberrant upward tracking into the upper tracts. That is exactly what we want to see.
But here is our aha moment. Notice the areas highlighted by the yellow arrows. During the filling phase, well before the patient is even attempting to void, we see distinct, bright radiotracer tracking upward into the ureters and kidneys. The valve is broken. This early detection is a massive strategic advantage of the direct continuous imaging protocol because we're catching the reflux before the high dynamic pressures of voiding even begin. And this sequence perfectly demonstrates exactly why multi-phase continuous imaging is mandatory. Look closely. In this sequence, the filling phase actually looked completely normal. The reflux was totally hidden, but the exact moment the patient enters the active voiding phase, the intense dynamic pressure triggers the VUR, forcing the tracer all the way up into the kidneys, where it persists visibly into the post-void frames. Honestly, if we hadn't imaged the entire continuous process, we would have missed it entirely.
And you know, radionuclide cystography isn't just about visually spotting the reflux, it provides incredibly precise data. By taking the voided volume, multiplying it by the post-void gamma camera counts, and dividing that by the pre-void counts minus the post-void counts, clinicians achieve an exact continuous mathematical quantitation of the post-void residual volume. So we aren't just looking at pictures here, we are calculating the literal exact physics of the patient's urinary function.
Finally, Section 5. Strengths and limitations.
Let's look at the overall balance sheet. On the strength side, the advantages are just immense. A drastically lower radiation dose of just 5 millirads, considerably higher sensitivity for detecting minute, microscopic amounts of reflex, and of course, that ability to perform exact mathematical quantitation. However, there are limitations. RC cannot reliably detect isolated distal ureteral reflex. It intrinsically lacks the fine, crisp, anatomic spatial resolution you get with traditional radiographic contrast, which means that formal anatomic grading of the severity of the VUR is definitely more difficult.
Which really leaves us with the ultimate clinical question, and kind of the core of our detective story today. Knowing all of this, when you are treating a young, developing patient who may need lifelong monitoring, is slightly less anatomical detail a worthy trade-off for protecting that child with 1/20th the radiation exposure? It's a powerful question that sits at the very heart of pediatric care. I really hope this explainer has given you the insight to understand exactly why so many medical professionals answer with a resounding yes. Keep exploring, keep asking questions, and I'll see you in the next one.